Everybody, and thank you for joining us with the Mountain View Public Library today. My name is Rick Hansen. I'm one of our youth librarians here. And for noon at Zoom, we're talking about navigating type 1 diabetes with Dr. Farrell, Dr. Valenzuela, and Dr. Seeley. They come from various departments within the Stanford medical system, and we're thrilled to have them speaking with us today with a presentation and opportunity for Q&A. I'm going to turn it over to you guys. Thanks so much.
Hi,
Thanks, Rick.
Thank you. So Dr. Farrell and I are both endocrinology fellows, and then Dr. Valenzuela is one of our attendings. And so we are going to share some slides and go through type 1 diabetes, and then open it up for questions at the end. And I think Dr. Farrell is going to share the slides. So we can start off with our disclosures and conflicts of interest. None of us have anything to disclose. The presentation only reflects the opinions of the three of us and does not reflect the interests or opinions of Stanford or Stanford Children's Hospital. We have several objectives today. We want to provide you with some background information, and we're going to start broad. So we're going to start with how our body processes nutrients, and then we'll talk about signs and symptoms of diabetes in children. And then we'll also talk a little bit about the different types of diabetes. And then finally identify resources available for families with children with type 1 diabetes. So first off, we'll start with how our body processes food. So during digestion, our body processes macronutrients, which are carbs, proteins, and fats, into individual units that can be used by our cells. And so the more scientific words for those would be carbohydrates become glucose, proteins become amino acids, and then fats become fatty acids. And so during metabolism, the body cells use the nutrient units to generate energy through something called ATP. And then the byproducts of this process are heat and chemical wastes. And so for our talk on diabetes, we'll focus in particular on carbohydrate metabolism. But it is important to point out that our body prioritizes carbohydrates and protein as its primary energy sources. And then we'll use fat as energy only when carbs and protein are not available. So after digestion, carbs are turned into sugar, or what we would call glucose, and released into the blood. And in order for our body's cells to take in the sugar to use as energy, we require insulin. And so insulin is a hormone that we like to use the analogy of it acts as a key to unlock the door into the cell and allow the sugar in. So without insulin, our bodies are not able to utilize the glucose or the sugar to use as energy. And so the pancreas is an abdominal organ with lots of different functions, but one of those functions is making enzymes that help break down the food that we eat as part of digestion. But it also makes insulin and another hormone called glucagon. And together, insulin and glucagon help regulate our carbohydrate metabolism. They help regulate how much glucose our body has in the blood and that's available to our cells. And so within the pancreas, there are cells called beta cells, and those are the cells that produce insulin. So as a review, when we eat food, our body processes the macronutrients into individual units that our cells can then metabolize into energy. And for carbohydrate digestion, glucose is released into the blood. And in order to be used as energy, glucose needs to enter our cells. And insulin is the key that admits sugar into the cells to be used as energy. And so next we'll move on to kind of some signs and symptoms of diabetes. So things to look out for, things to be aware of. And so symptoms that you may see, kids will pee more frequently. They may start drinking more than usual. They may feel extremely hungry or very tired. They may also experience blurry vision or have weight loss or be a little bit more irritable than they have been in the past. And what leads to these symptoms? So high sugar in the blood spills out into the urine. which makes us pee more. And so that's why kids will often have frequent urination and thirst and often become dehydrated early on if they have diabetes and they aren't yet diagnosed. And then people with diabetes can't use carbohydrates as their energy source because they don't have insulin. And so therefore the glucose gets trapped in the blood. And it can't make its way into the cells because insulin isn't there to act as the key. And so symptoms are actually similar to starvation, where people may experience extreme hunger and weight loss because their body isn't able to utilize the energy. And so they feel very hungry. Their body's trying to tell them that they need to eat more because they need more energy available. But even when they do that, they're not able to use that energy. And then the high sugar levels can also make you feel very tired, irritable, and can lead to blurry vision. And so like I was saying, in type 1 diabetes, the beta cells, or those cells within the pancreas that make insulin, have been destroyed. And that's due to something called an autoimmune process, where the body's own immune system attacks certain cells within the body. And so the beta cells have been attacked and destroyed. And so therefore the body's not making insulin. And so while carbohydrates are still digested and released as glucose into the blood, the cells don't have that key or the insulin to bring the glucose into the cell to use as energy. So the glucose gets stuck in the blood and goes higher and higher. And that's something that we call hyperglycemia or high blood sugar. And so when glucose can't be used for energy, the body still needs to function. And so it relies more on amino acids or fatty acids. And those are the units that come from protein and fat. And so like I said at the beginning, your body will prioritize carbohydrates as its primary energy source. When carbohydrates aren't available, it moves on to relying on amino acids and fatty acids. And so the body will start essentially scavenging or breaking down its own muscles and fat stores as a way to get energy because it's not able to use the carbohydrates or the glucose that are circulating in the blood because there's no insulin. And so breaking down of fatty acids or breaking down of the fat stores in our body causes something called ketones. And this has become a popular term. So like the ketogenic diet or the keto diet is where you essentially you eat a much higher proportion of fat in an effort to have your body start breaking down the fat stores that your body has. And so these high level in kids with type 1 diabetes, when they're not able to use carbohydrates as their primary energy source, the body starts breaking down the fat and leading to ketones. And high levels of ketones can make the blood more acidic. And if it gets acidic enough, that becomes a medical emergency. And so now that we've talked a little bit about kind of what type 1 diabetes is, we should talk a little bit about how we make that diagnosis. And so the diagnosis for diabetes is a fasting blood glucose of greater than 126. So the fasting blood glucose would be the child hasn't eaten yet for the day, and we check a blood sugar. If it's greater than 126, that's one of the check marks that we need to make the diagnosis of diabetes. In children who aren't symptomatic or who are at high risk of having diabetes, we can also check something called an A1C, which is our average. It gives us an average of what the blood sugar has been over the past 3 months. And so an A1C greater than 6.5 is another way that we can make a diagnosis of diabetes. And so, like I said at the beginning, there's actually 2 different types of diabetes. There's type 1 and type 2. There's also some other kinds, including gestational diabetes, which is diabetes caused by pregnancy, or diabetes due to medications. But type 1 and type 2 are the most common types. So those will be the types we talk about today. And so type 1 and type 2 are really differentiated or categorized by the cause of the high blood sugars. So for type 1 diabetes, like I was saying, it's really more of the inability to produce insulin. whereas type 2 is a varied response to the insulin. So the insulin's there, the body's just not responding the way that we expect it to. Type 2 diabetes is much more common than type 1. And a lot of times people think of type 2 diabetes in adults. However, we are starting to see type 2 diabetes develop more and more in children. And the way we manage the two different types of diabetes is very different. So for type 1 diabetes, like I was saying, our body has an immune system, and that's typically what our body uses our immune system to fight different illnesses. However, in an autoimmune disease, the immune system gets confused and identifies some parts of our own body as foreign, and therefore starts attacking the immune or our own cells. In type 1 diabetes, the immune system thinks that the beta cells, or the cells in the pancreas that make insulin, are what we call like foreign invaders. And so the immune system starts attacking the beta cells, which leads the body to lose the ability to produce insulin. And so a common question that we get is why this happens. And the answer is really quite complex. So people with diabetes inherit a genetic risk. And this is similar to how we inherit other diseases like high blood pressure, for example. But during the course of our lives, something in the environment can trigger our immune system to activate against the beta cells in our pancreas. And this trigger could be a viral infection, but in most cases, we actually don't identify the exact cause. And once the immune system is activated against beta cells, the ability to produce insulin decreases until the body produces no insulin at all and is completely unable to process sugars. And at that point, that's when we say the person has developed type 1 diabetes. The development of type 2 diabetes is quite different. So people inherit a genetic risk for something called insulin resistance, and that can go along with obesity and decreased function of beta cells in the pancreas. And so essentially the body has to, so insulin resistance is when the body doesn't respond appropriately to insulin. So the pancreas is making insulin, the beta cells are working as they are supposed to, but the body isn't able to utilize the insulin appropriately. And so the pancreas has to keep making more and more insulin to try to keep up and tell the body to respond the way that it wants to. And so together, this can lead to dysfunction in how the body utilizes insulin and how the pancreas actually produces insulin, which can lead to high blood sugars and then therefore type 2 diabetes. And so essentially type 2 diabetes and insulin resistance, there's a lot of blood sugar there's a lot of blood sugar in the bloodstream, and the pancreas is trying to keep up. So it's making more and more insulin to try to get the blood sugar into the cells so the cells can use it as energy. But over time, the cells stop responding to all that insulin, and therefore we say they become insulin resistant. The pancreas keeps trying though. It keeps making more and more insulin to get the cells to respond, but eventually we're asking too much of the pancreas and it just can't keep up, and the blood sugar keeps rising. And so that's when we would say that type 2 diabetes has developed. And so our treatment goal is a glucose. So for type 1, like I said, how we manage these two are quite different. So for type 1 diabetes, our glucose goal is between 70 and 180. And then we always work really hard to prevent what we would call like acute decompensation. So that would be where the patient develops ketones, doesn't have insulin on board, has very high blood sugars. And then we also want to prevent complications that are associated with high blood sugars, which is why we have that goal glucose range of 70 to 180. And then to keep kids safe, we also want to minimize episodes of low blood sugar, because that can also be really scary for families. For type 2 diabetes, the goal of treatment is to target the underlying causes of insulin resistance. So this includes things like lifestyle changes with diet and exercise and managing excess weight. We also now have oral and injection medication options that can reduce insulin resistance and actually help lower blood sugars. However, sometimes insulin is necessary to achieve glucose control in patients with type 2 diabetes, but it's not usually our first line of treatment for type 2. So I'm going to hand it over to Jeff to talk a little bit more about resources available to families for kids with type 1.
That was a great overview. I think just as a quick recap, so type 1 diabetes is when you don't have any insulin, your body has stopped making insulin. Type 2 is when you have insulin present, but your body isn't able to utilize it correctly. But both lead to high blood sugars, and that's what we call diabetes. I'd like to just start by talking about how we monitor blood sugars. So there's a couple different ways. Often people are familiar with the device you can see here on the left. This is called a glucometer. Glucometers are what we call point of care tests, where they use a small drop of blood, usually use something like a small needle called a lancet. People will tend to poke the side of their finger and then use that drop of blood to do a quick analysis, and it will check the average or the blood sugar at that point in time. That's been the mainstay of diabetes treatment for a long time, and we can use those blood sugars to decide how much insulin somebody might need, and it's very context dependent. So did they just eat a meal? Are they fasting? Those sorts of considerations are important to interpret how a blood sugar should be responded to. On the right side of the screen, you can see something newer. These little puck-shaped devices are called CGMs, which stands for Continuous Glucose Monitor. These are newer devices, and they're getting better quickly. They're getting smaller and less invasive, but essentially they have a small probe, like a little piece of metal that's underneath the skin that just sort of dwells in that space in between the cells. And it's actually measuring the amount of sugar that is in that fluid between the cells. So it's not actually a blood sugar necessarily, but it's a good proxy for a blood sugar. And they tend to follow what the blood sugars have done in about the last 30 minutes. So a CGM is maybe a little bit behind where a blood sugar off a glucometer would be, but we've gotten really quite accurate with them. They're usually about 20% in range of where a glucometer would be. So it's really useful to trend where blood sugars are going. It can say, hey, you're going down quickly or you're going up quickly. And it's a really great tool. Often you can just use your phone to get the reading off the CGM, and they can last anywhere from like 10 to 14 days. So quite valuable in that aspect. And then Dr. Valenzuela and Dr. Seeley, if you guys notice that there's any comments or questions in the chat, will you let me know, since my screen is the PowerPoint at the moment?
Will do.
Great. So you can't have a talk about diabetes without talking about insulin. Insulin is the medication that we use to keep people's blood sugars in a target range. And so if your body is not making insulin, the best way to improve a blood sugar is to give insulin. Typically, like Kylie said, is made by the pancreas. At this moment, you can see on the left, this person's using an injectable pen to give the insulin. Usually insulin is contained in a cartridge, and you can decide how many units you would like to give by twisting the cap on the end. There's a small needle that affixes to the tip of the pen that you then give yourself an injection of. We like to give insulin in what we call the subcutaneous fat. That's the layer of fat right below the skin and above your organs. So in this case, it would be like above the abdominal organs. You see how she's pinching there? We like to say, if you can pinch at least an inch, you can give yourself insulin there. We don't want you to give insulin into the muscle because it doesn't work appropriately. There's different types of insulin, and so they release over certain periods of time. We'll give one type of insulin after you eat a meal because it acts in the next 3 to 5 hours. We give a different type of insulin before bedtime that lasts over 24 hours and just dissolves more slowly, and that acts as like a baseline insulin. So you can see there's different approaches, and we would be using a blood sugar to determine exactly how much insulin to give at that time. On the right side is something newer. These are insulin pumps. They've been out for a while, but we're still developing better and better pumps. That one's called a Tandem T-Slim. You can see they've got a touch screen on the front, so this one doesn't necessarily need a phone connected to it to operate. There's a little patch, almost a sticker on the stomach, and there's a tiny cannula. A cannula is another word for like a small plastic tube. So it uses a needle to put this device on the skin, and then the needle retracts and it leaves that cannula there. So we can infuse insulin into that subcutaneous space right underneath the skin and give insulin into the fat there. You would change the locations every once in a while, but that pump, you can essentially tell it how much insulin you'd like to give. There's a reservoir of insulin inside the pump, and it uses the tubing to get the insulin underneath the skin. Quite effective devices. All right. So closed loop or hybrid systems are the future of diabetes. They're, I think, the newest development at the moment that has been mass adoption. And using those CGMs, the continuous glucose monitors, with a pump that can read data from the continuous glucose monitor, we can actually use the two to, like, with an algorithm to help keep blood sugars in a target range. So we're trying to replicate the function of the pancreas as much as possible using just insulin, which is a limitation. But as you can see, say this person's blood sugar here was around 120 and they started coming down. The amount of insulin you can see down here decreases and stops as they're downtrending. And this data would be coming from the CGM. And then once their blood sugar starts to go back up after they've eaten a meal, the CGM tells the pump, hey, their blood sugar is going up. It's about to be outside the target range, or hey, they just ate a meal, and it starts to give more and more insulin. They can even give automated, what we call a bolus, like as if they were giving an injection, but they can also replicate that long-acting insulin by giving small metered doses over time. These systems are really great and have been a really wonderful new method of keeping people's target sugars in range with less effort. Because as you can imagine, having to count carbs, check blood sugars, and give insulin injections for blood sugar management can be quite labor intensive. And so a lot of these new technologies are trying to reduce the amount of hands-on time that someone with diabetes needs to take care of their systems to keep their blood sugar within the target range. We've got some new treatment targets in type 1 diabetes. The data in the past, let's see, I was just going to say, before I move on to this next part, is that we're sort of understanding better and better what target blood sugar people actually need to be in to make sure that we don't develop long-term complications of diabetes, like kidney problems, eye problems, and blood vessel problems. We are using this diagram to show different places where we can intervene within the life cycle of diabetes development to prevent the disease or slow the disease progression. So this first one here, immune modulation, we're trying to see if we can develop drugs to actually blunt the immune response against the pancreas. Beta cell replacement, meaning actually giving back beta cells or trying to use stem cells to create new beta cells from someone's own body. Stage 1, 2, and 3, ways to delay that progression from we have an immune response, but the beta cells aren't gone yet. How can we lengthen the amount of time that those beta cells persist despite the immune attack? Those sorts of things. There's lots of new ideas in diabetes that are quite exciting. This slide is just important to say that, technology takes time to be adopted and it needs to be safe. And so, when we're talking about a medication like insulin, where if you give too much, someone's blood sugar could go dangerously low, it's important that our systems are reliable. And so these have taken decades to get to maturity. And so some of the things that I'm going to talk about next are already existing, but not massively adopted because they haven't been proven to be safe in like a large population. As you can imagine, we're pediatricians, and something that is very important to the care of our patients is the support that they have from their family and friends. Kids who are diagnosed with diabetes often aren't even old enough to really understand what the disease is, much less how to take care of it. A lot of this centers around counting the number of carbs that you've eaten so that you have an idea of the insulin response that your pancreas probably would have done if the beta cells still were functioning properly. So people have to be able to count their carbs. They have to be able to check their blood sugar on their own, be able to give the insulin themselves consistently. And so all of this is really tough in some of our younger patients. And as they get older, they get more and more independent, which is really nice. We have things like diabetes camps that kids can go to where they have a place to feel like they're not the only one at school with diabetes, that sort of thing. And we found that that can be really motivating in becoming more independent in their diabetes care. As kids approach the teenage years, we tend to see it gets a little more difficult sometimes for kids to be independent on their own and bought into their care as they go through some of those rebellious phases. And then as they approach more maturity and adulthood, it often becomes more of an independent and easy process. You can't give a diabetes lecture on October 30th without discussing Halloween. So we have here a resource from the Juvenile Diabetes Research Foundation, and now considered breakthrough type 1 diabetes. And this is a handout that they give to families that gives them an easy way to know how much each piece of candy contains as far as carbohydrates. And this is sort of what I was talking about, this parent-child relationship becomes quite important. And it's something we actually spend a lot of time on in our appointments. Sort of, how is the relationship between the parent and the kid? Does the child feel like the parent's hovering all the time? Does the parent feel like the child's taking care of their diabetes appropriately? These are very important conversations. And we even have resources like diabetes psychologists who are able to help us really dig down into the underlying causes of some of the conflicts that can occur between parents and kids. It's also important to remember that it's not just the parent taking care of the child. Often at school, it's the nurse who's going to be doing a lot of the injections or management of their diabetes. And so we're in tight communication with all of those parts of the child's life. In school considerations, like I was saying, there's a nurse or somebody at every public institution. It's required by law that there's someone who could take care of a child with diabetes if they exist in their class. Some new technology that we're trying to develop that hasn't really become successful yet. We need to find a way to stabilize glucagon. So in every body system, there's usually something that pushes and something that pulls, like an oppositional force to insulin, for example. So if insulin is the hormone that our body uses to decrease blood sugar levels, glucagon is the counter-regulatory hormone that actually increases blood sugar levels. And the pancreas can make both of those. But once the beta cell dysfunction happens and we can't make insulin anymore, oftentimes our body's systems for keeping glucagon normal also kind of go off the rails. When you're giving insulin through an injection, your body doesn't know that it didn't come from the pancreas, and that insulin production actually suppresses glucagon. So if we give too much insulin, the body's not able to mount an appropriate response to a low blood sugar by making glucagon because that insulin is present. Whereas if it was all regulated by the pancreas, it would be able to maintain itself appropriately. I only go into this much depth because it is a dream of a lot of endocrinologists and diabetes experts to have a system that utilizes both of these hormones with those CGMs to keep blood sugars as tight as possible. We're not there yet, but there's a lot of people working on something like this. Other things would be the breakthrough in AI, to start using AI to improve our algorithms of talking from the pump to the CGM. As you can see, this picture on the left is actually, it's a pump that is all in one contained on the body. So that talks to your phone or a receiver, and you don't have to have a tube connecting to an infusion site. It's all in one. So that's pretty cool. That's called the Omnipod. Other methods of giving insulin, there's actually more in the adult world, but they can use inhaled insulin. And on the right side, this is just a diagram of the anatomy of the gastrointestinal system. But it's important to remember that in our body, the insulin is actually coming from the pancreas, and it's injecting it into the bloodstream more than really going into like the skin. And so to be as physiologic as possible, it'd be really cool if we could create insulin pumps and reservoirs that exist within the human body and inject straight into the bloodstream rather than going through a skin that's not as physiologic. So this actually does exist, and people are working on it, but it's not, again, mass adopted and hasn't been proven to be safe in children. So this is a medication called Tzield. This is a monoclonal antibody, teplizumab. They make these names really hard to say, but essentially this is it's a antibody against some of our proteins on the white blood cells that actually are attacking the beta cells. So the idea here is to extend that phase 1 to phase 3 of type 1 diabetes progression by attacking or by inhibiting the white blood cell's ability to attack the beta cell. They still exist, but they're not able to do their job. And this has been shown to lengthen the amount of time from recognition that someone has the antibodies that will lead to type 1 diabetes and actually having the clinical manifestations of type 1 diabetes. And that's pretty cool because we know that people who have type 1 diabetes, their family members, their immediate brothers and sisters, parents, and children as well, have a higher risk of having type 1 diabetes than the general population. So we have started to screen those populations, the brothers and sisters, and actually are finding antibodies before they're showing signs of diabetes. A medication like this could give them years of better glucose control without needing to give insulin and check their blood sugars all the time. So this is really, it's a beautiful breakthrough in diabetes management. It's important, especially in pediatrics, because it's a vulnerable population, to talk about equity and access. A lot of these technologies already exist to keep people's blood sugars in tight control and prevent long-term problems from diabetes. The outcome is a lot better than it used to be because of all these technologies, but one of the big problems is that they're still quite expensive and it's difficult to get them in other parts of the world. And so we have a lot of work that we need to do on making sure that access to this type of care is equitable across all nations and for all people, despite socioeconomic status or where you were born, because the products that we have work and they're actually not that expensive to produce. It's just figuring out ways to get it distributed evenly. All right, so that was a lot of information. Just to summarize quickly, type 1 diabetes happens when the beta cells from the pancreas are no longer able to produce insulin. So you cannot use the blood sugar to actually feed the cells of your body. Type 2 diabetes happens when the body can't use the insulin, or there's not enough, or the cells are resistant to insulin, and so the body's making lots and lots of insulin, but it's not actually having the effect that it needs to. Both type 1 and type 2 diabetes end up with people having high blood sugars. Insulin is the key that lets sugar be used by the cells, and without it, people have high blood sugar. We can use technology to deliver insulin and monitor blood sugars, and that technology is getting better and better every day. And then people who have diabetes do not have to manage this disease alone, especially the pediatric population relies on their families and friends to help support their diabetes management. All right, we had some questions we wanted to go through if people are amenable. Otherwise, actually, I wanted to see, are there any questions in the chat? No? Okay. So, question 1, what are the 3 macronutrients our body uses for energy?
So the 3 main macronutrients in our body are carbohydrates, proteins, and fat. And like I said, our body prioritizes carbohydrates as the primary source of energy. And when carbohydrates aren't available, or if our body isn't able to utilize the carbohydrates or glucose that we have in our body, it will then start using protein or fat as its primary energy source.
Fantastic.
And are some of the signs, if the body is not using the carbohydrates, that frequent urination, does that come up into that situation, or a different one? Could patients have headaches frequently? What would be a sign you would see in that situation?
Yeah, Rick, great question. So when the body has a lot of glucose so a high blood sugar, one of the ways it tries to get rid of that is by peeing it out. And so that will cause patients to pee much more frequently and feel very thirsty because they're peeing so much. So then they'll also start drinking more. So that's things that we generally tell parents to kind of keep an eye out for. So excessive thirst or excessive urination would be 2 things. High blood sugars or high ketones can make kids cranky or more irritable than usual. Blurry vision is also something we see with high blood sugar. So all of those things would be things to look out for.
Lastly, on that
Callie,
one,
there's a
sorry, I just want to say, you mentioned some of those are early signs. Are there late signs, or would those qualify as late signs in the body from a patient?
So I think that would show up if your blood sugar was high either way. And so I guess early signs would be something you could watch out for would be like weight loss. If kiddos aren't able to utilize the blood glucose or the sugar for energy, they'll just start eating more, but they won't gain weight because their body is peeing out that extra glucose. So that would be the other maybe sign to look out for. But I don't know if Dr. Valenzuela or Dr. Farrell has a different answer.
No, I think in general, I think it's very hard to detect early type 1 diabetes, which is a big frustration for families. So I think Dr. Farrell covered that image of where it says stage 1, stage 2 diabetes. And I think that will answer some of the questions that people ask. But it's really, really hard to detect that you're at risk and you don't have elevation in your blood glucose levels. So the first step you will see, unfortunately, is already pretty advanced type 1 diabetes, because at that point you already need insulin. So yeah, at this moment in the US, there is no national screening for type 1 diabetes, but it's something that we think in the upcoming years. I know European nations are starting to think about, should we screen every child to see if they are at risk of developing type 1 diabetes? And there's currently multiple studies going on right now to see if that's something that is, it's a feasible thing. But at the moment, there's nothing to do.
And Novia asked a great question in the chat. She asked if, or they asked if genetic testing is done by the pediatrician for other siblings. So I guess it would depend on where you are, but here at Stanford, we have research studies available for siblings to do those testing studies. And so if there is a family member with type 1, you could ask the pediatrician to refer to endocrinology to do that testing, or you could look up on the internet. It's called TrialNet, is the system that allows for genetic testing for siblings or first-hand relatives.
Yeah, I'm
And
just
then,
sorry.
please.
So actually, you don't necessarily need genetic testing immediately. We test for antibodies. So the first thing that we need to check for is to see if you have one of the 4 antibodies. And then that can be, as Dr. Silly said, I will show the website that you can go for TrialNet. And then your pediatrician can order it, or we can order it as well. But you don't necessarily need to have the genes tested. We're able to identify the antibodies before necessarily needing genetic testing.
Mhm.
And then another great point in the chat, mental health for both the child and the family. So we are very lucky to have a clinical psychologist on our team who can help with both the patient themselves and with families, because it is a big adjustment. And like Dr. Farrell was talking about, it can often cause a lot of conflict in families because kids can often feel like their independence has been taken away. And so I completely agree that making sure we're connected with a psychologist or a therapist of some kind to help navigate that is very important.
I'll keep going with the recap here. Is question number 2, which cells normally produce insulin? Dr. Seeley, do you want to answer for us?
You're quizzing me. So the cells that normally produce insulin are called beta cells, and they reside within the pancreas. The pancreas is located kind of right here in your belly, just underneath your diaphragm, next to your stomach. And it's the beta cells that produce insulin, and that's what the antibodies that Dr. Valenzuela was talking about. The antibodies attack the beta cells so they can no longer produce insulin in type 1 diabetes.
Right. And then question 3, what causes type 1 diabetes?
Oh, oopsies. I skipped ahead. I gave the answer away.
Beta cell destruction. They can't make insulin. Awesome. Let's see, what does it say? Question 4, name 3 symptoms of hyperglycemia or high blood sugar and new onset diabetes.
I bet Rick can do this now.
Yeah, we just recapped
Right.
that.
We were talking about frequent urination as one sign. Then I'll just have to jump back to, weight loss.
Yep.
Due to that, those sort of being connected.
Okay.
And I just want to say headaches, but I think there was something else.
No,
Headaches, blurred vision.
Blurred
Yep,
vision.
you got it, Rick. Yep. So feeling thirsty, peeing more than usual, eating more, but also feeling really tired, losing weight, headaches, blurry vision, all of those things can be associated with high blood sugars and new diabetes. So if you're noticing any of those symptoms, it would definitely be a good idea to either go to your pediatrician or go to a local urgent care to get your child checked out.
Question number 5, name 2 methods of insulin delivery.
Dr. Farrell went over 2. So you can either use injections or you can use the newer technology, which is the pump. And so it would either be a shot into the subcutaneous tissue or a pump, which infuses the insulin into the subcutaneous tissue. So 2 different options.
Awesome. And then I really liked this last question. I thought this was really great. So I'm going to lay this scenario out for you guys. You're on an airplane and you just finished your movie mid-flight. You remove your AirPods to hear panicked shouting that a passenger on board is having a seizure. They are traveling alone, but the person sitting next to them saw them test their blood sugar earlier, so calls out that they believe they might have diabetes. There are no doctors on the flight. What medication do you instruct to the flight attendant to look for? This one's a little tough, but also probably the most relevant. Okay, we've got a suggestion here, a CGM. That's a good idea. Try to check their blood sugar. I love it. If we're looking for a medication, though, I think the CGM is more of like to measure the blood sugar right now. So yeah, so we would definitely see if we could get a blood sugar. Say it comes back low. They're having a seizure because their blood sugar is low. We want to get the sugar up. There's an injection we can give. Rather than trying to put any sort of sugar in their mouth, you can actually give glucagon. Yes, perfect. Nuvia got it. Glucagon. Yes, so that actually is going to bring the blood sugar back up by mobilizing sugar from your liver into your bloodstream. And then you can start to treat their blood sugar once they've regained consciousness. You can actually give them more sugar, check their blood sugar from there. They may have had too much insulin.
I think glucagon is one of the few things in medicine that is actually named appropriately in a way that makes sense, right? Your glucose is gone, glucagon. So you give glucagon when your glucose is gone. Everything else in medicine we've named so it's confusing, but this one actually makes sense.
Thank you. And there's a lot of great information on Stanford Children's Health, stanfordchildrens.org website as well. So I really want to extend a huge thank you to Dr. Valenzuela, Dr. Seeley, and Dr. Farrell for their time. It's been so great having you here and learning so much about everything that's out there, resources for help, and what to be aware of to support those who have and are dealing with diabetes. So thank you so much to everybody. Appreciate it.
Absolutely. And thank you for inviting us.